Good morning, everyone. This is Cheryl Larson with the Midwest Business Group on Health, and welcome to today's webinar on migraine management. We always like to go over a little bit about what we have coming up, and we have one slide for you today. You'll see that we've got our second webinar talking about the new employer member benefit with Wilcoa. So just a quick reminder for those of you on the phone, we are offering one complimentary membership to Wilcoa for each of our employer members. Last week we had a webinar just walking through all the benefits and services that are available, and on the 23rd we will do the same. We also have on September 11th our annual member meeting and social event, and we're focusing on social determinants of health for this event, but the majority of it is intended to be social. So we'll have a lovely lunch, we'll have a reception afterwards to visit and network, followed by a discussion. And you'll be seeing more information in your weekly email on that. If you have any questions, feel free to contact the staff, but you'll see in our images below, we're going to also be given the opportunity to go on the sky deck at the Willis Tower, formerly Sears Tower. Still have to get that in there. And so we look forward to seeing you there. We do have a limited number of people who can register, so make sure you register today. I'm very excited and grateful for the expert speakers we have on the program today. And I'd like to introduce them all briefly, starting with Dr. Wayne Burton. We have known Wayne for many, many years. He has over 40 years of experience in healthcare and corporate occupational medicine services. This includes healthcare data integration, wellness and disease management, and integrated disability management. Wayne was the Chief Medical Officer for American Express from 2009 to 2017. Prior to that, he was the Corporate Medical Director for JP Morgan Chase and its legacy banks for more than 25 years, starting the company's first wellness program in 1982 and integrated health management data system in 1987. Wayne has been an active member and a longstanding friend of MBGH. He was also a former chairman of the board, and we are really excited to have him here today because he is one of the true original employers that integrated migraine management efforts when he was with those employers. So we're going to hear some case studies from him today. Our second speaker is Gay Fortner. Gay is the president and CEO for Healthcare 21 Business Coalition, which is a sister coalition committed to market-based healthcare reform, value-based purchasing, and quality improvement. Gay has developed, managed, and evaluated a number of studies that are dedicated to the management of high-cost conditions, chronic diseases, lifestyle risk factors, and topics of concern at a national level, delivering a regional market approach. She is a fellow board member with me on the National Health Alliance of Healthcare Purchaser Coalitions, a good friend and colleague for many years. And finally, we've got Tom Sondergeld. Tom is Vice President of Global Benefits for Walgreens Boots Alliance. He is responsible for the global health and well-being strategy at Walgreens. He has spoken at many local and national events on private exchanges, HR process improvement, benefit outsourcing, benefit plan design, wellness integration, and on-site health centers. Tom is MBGH's immediate past chair, an active board member, and we are thrilled to have him join us today to talk about employer experiences as well. Finally, as we were preparing our slides for today, I wanted to me, this really resonated. The World Health Organization has ranked migraines as one of the 10 most disabling illnesses and the third most common medical disorder on the planet. And in the US, this is affecting 1 in 8 American adults. Migraine impacts productivity on the job, and more than 90% of workers are unable to function normally during their migraine. You may hear that stat again throughout our presentations this morning, but I think it's really important for us to understand the impact to the employee/family member, and especially for the work of the impact on productivity. With that said, I would like to introduce Denise Giambalvo, MBGH's Vice President, to take us to the next slide.
Thank you again, everyone, for being here today. As Cheryl has stated, we have an exciting lineup of speakers, and our topics are also of great interest. We'll be defining migraine and how it impacts the employers, taking a look at the epidemiology and economic burden of migraine, the impact of migraine education program in the workplace. We also have solution-oriented tools for employers. And then an employer initiative from Tom Sondergeld. So Wayne Burton, Dr. Wayne Burton will kick it off with the defining migraine. Then we'll move into Gay, and we'll come back to Wayne again as he'll talk about the impact, and round up with Tom and a few comments from Cheryl regarding MBGH and our toolkit.
Thanks very much, Cheryl and Denise. It's a great honor to be on this program with Gay and Tom. So I'm going to begin with 3 questions for the audience, virtual questions. And the first one, raise your hands. We can sort of see them virtually here. One is, how many of you have or know of someone who has migraine headaches? And my guess is everyone here and virtually knows someone or has migraines themselves. The second question for the group is, how many of your organizations have migraine on your radar screen? And I can see that there's only maybe 1 or 2 hands up on that. And third, my third question is, how many of you have data on the prevalence or cost of migraine to your organizations? And again, I can see that virtually no one does. There's just 1 or 2 hands I see up through my special vision glasses here. So today I'll be presenting an overview on migraine headache, its impact on the employed population, and published results of a worksite migraine disease measure program that we developed. You are in good company if you have migraine headaches. People with migraine are leaders, thinkers, painters, writers, and artists. Migraine may bring a host of symptoms and challenges, but it also can be associated with greatness. Actually, the father of occupational medicine, Bernardo Ramazzini, in 1700, probably had migraines triggered by his exposure to bad smells in the grimy 18th century workshops of Italy. Vincent van Gogh, one of the most famous and talented painters, is suspected of suffering from severe migraines. The painting depicted in this slide, art experts have speculated that the halos and swirling patterns and colors of paintings, like in this painting called Starry Night, are representations of Van Gogh's auras of migraine headache. George Seurat, also a famous artist, is also thought to have painted this famous painting, Bridge on Corbeil, during his migraine. And finally, Lewis Carroll created the Cheshire Cat as part of Alice in Wonderland during his migraine. Many famous women have also suffered from migraine, such as Academy Award-winning actress Elizabeth Taylor, songwriter Carly Simon, who sang You're So Vain, Whoopi Goldberg, and many other famous women. A migraine is a type of headache that differs from other headaches by causing moderate to severe pain and other symptoms. It's not just a headache. The symptoms can include throbbing or pounding headache, feeling sensitive to light or sound, we call that photophobia and phonophobia, nausea and vomiting. Some migraines include an aura. An aura can make a person see spots or flashing lights or bright spots before the headache starts. Sometimes auras can include pins and needles sensation on the face or arms, trouble thinking, trouble concentrating. These headaches can last from a few hours to several days and can affect day-to-day activities. If one parent has migraine, then there's a 25% chance that one of their children will have migraine. If both parents have migraine, there's a 75% chance that a child will also have migraines. So although a physician needs to evaluate and rule out severe causes of headache, obviously brain tumors and other severe things, there are 3 symptoms that strongly suggest that a person has migraine: nausea, photophobia, sensitivity to light, and having disability as a result of the headache. So if a person is nauseated, or sick to their stomach when they have a headache, it's maybe highly suggestive that it's related to migraine. If light bothers a person's eyes when they have a headache, another symptom. And if the headache has limited a person's activity for a day or more in the past 3 months, also suggestive. So if someone has 2 or 3 of the symptoms, then the headache is highly suggestive of migraine, and 3 of those 3 symptoms, it's very highly suggestive that it's related to migraine. Clearly, other reasons have to be excluded. Over 30 million Americans suffer from migraine, and as Cheryl mentioned, that's 1 out of 8 Americans. There are some estimates that over 40 million Americans suffer from migraine. Children can also have migraine. It's not limited to adults. If you don't have migraines, the chances are very good that someone in your household had migraines. And this slide shows that the prevalence of migraine is during the working age population, basically from mid-20s to age 59 or 60. Migraines are relatively uncommon after the age of 60. People, for various reasons, no longer have them. And you can see that the prevalence of migraine in terms of women to men, about 17% of women have migraine, and about 6% of men have migraine. So people used to think that migraine is just a problem, a disease and disorder that women have. Men have migraines also. As Cheryl mentioned, the productivity losses of migraine in some studies far exceed the direct costs of migraine, but both the direct costs and indirect costs are significant, and Gay will be going over some excellent recent research that they've conducted at Healthcare 21. Migraine is one of the leading causes of lost work days and disability worldwide. And in the United States, migraine was ranked number 5 for disability lost years from diseases, injuries, and other health factors. Only low back pain, major depression, diabetes, and other musculoskeletal disorders ranked higher in lost disability time than migraine headache in the United States. As I mentioned, there are between 30 and over 40 million Americans with migraineurs. Here's some old data that showed that about $11 billion in costs were related to direct costs, outpatient costs, medication costs, inpatient costs, emergency room visits, and about $11 billion in indirect costs related to missed work days. Clearly, this is a significant underestimate of the real costs. Headache is generally more common in employed populations than asthma, diabetes, or high blood pressure. Yet headache treatment is really something that's poorly understood by many physicians. We don't have a lot of training on headaches during our medical school and residency training. It is estimated that almost half, 44%, of patients with migraine are either not diagnosed or misdiagnosed. There's several reasons for this. Headache patients have multiple symptoms, multiple problems, and comorbidities, including depression, anxiety, allergic disorders. Sinus headaches are frequently misdiagnosed as sinus headaches rather than migraine. So physicians are very busy, as we know, limited amount of time. And in my own practice of internal medicine, it was not uncommon that a patient, as they were leaving, would say, "Oh, doc, I have a headache." Well, first I had to exclude more serious causes of headaches, but then most of the time I'd ask the patient to come back so we'd have time to go over the reasons for headache. And most of the time, it's very common that headaches were related to migraines. Now, the first goal of migraine treatment is to have a patient identify and avoid trigger factors. Trigger factors can be divided into 4 main groups. These are factors that trigger someone's migraine headache. And those 4 main groups are environmental, lifestyle, dietary, and physical. Environmental factors include such things as flickering lights, noise or sound, changes in the weather, and various aromas. Triggers are not the same for everyone. One person may have different triggers at different times. One person may have more than one trigger. Lifestyle factors such as fasting, irregular sleep, more sleep or lack of sleep, irregular meals also have been known to trigger migraines. Dietary factors, aged cheese, so-called stinky cheese, can trigger migraines. Alcohol, monosodium glutamate, MSG in foods, caffeine, amongst other dietary factors. And physical factors, stress, hormonal, and fatigue. Exercise does a lot of good, as you know, and it's important, but the time of day may trigger migraine in some patients. So these are just a few of the triggers, and we ask patients with migraine or with headache to do a migraine diary to see when their headache comes on and what symptoms, what triggers may be causing it. In many patients, the number of headaches can be significantly decreased or actually eliminated by eliminating these triggers. I'd now like to talk briefly about migraine treatment. And basically, migraine medication involves 2 different types of treatment. One is the treatment of acute migraine headaches, and 2 are medications to prevent migraine headaches. So what medications work for an acute migraine? For some people, simple over-the-counter medication, anti-inflammatory medications such as aspirin or ibuprofen may do the job for someone who has occasional migraine and they're not severe. For other people, other patients, they can sense that a migraine is coming on and they can treat the headache immediately with a prescription medication such as a triptan that can greatly decrease the severity of the migraine headache. However, these medications, triptans, can only be used generally once or twice a week at most. If the headache is severe and doesn't go away, opioids are not uncommonly prescribed, especially in the emergency room, and unfortunately, it is contributing to this opiate crisis that we're having. So opiates are generally not recommended. The American Academy of Neurology does not recommend use of opioids because of the addiction possibility and true problem. So for people that have 4 or more migraine days a month, they should talk to their physician about a medication to actually prevent or decrease the frequency of the migraines. There are a number of preventive medications that have been used over the years, and these medications actually in the past have been ones used for other reasons. For example, beta blocking drugs have been used to treat high blood pressure for many years, and they can prevent migraines in some patients. Tricyclic antidepressants, anticonvulsant medication, as well as some hormonal therapy have been used in patients. Botox has also been used and effective in some patients with chronic migraine. But all of these are medications in the past that have just been found to be helpful in some migraine patients, and it's been trial and error. About a year ago, a medication came on the market, and now several have come on the market that really have been specifically designed to treat one of the pathways that cause migraine headaches. And this group of drugs are called calcitonin gene-related peptides, CGRP. You probably, no doubt, have seen advertisements on the television, in the media, in newspapers, as well as on the radio for these drugs. They've literally been life-changing drugs for certain patients that have severe migraines and frequent migraines, so-called episodic and chronic migraines. The exact mechanism is not perfectly determined, but let me tell you that this molecule, this CRG molecule in general, has been found to be elevated when a patient has migraine, and when they take the medication in at least half the patients, that level goes down and prevents the migraine from occurring. So this group of medications, there's two mechanisms. One mechanism blocks the receptor site and one attaches to the molecule. I'm not going into details, but it's the first time that we have drugs that are specifically designed to attack the pathophysiology of migraine. So with that, I'm going to turn things over to Gay, who's going to talk about the economic research on migraine that they've been working on and published now.
Thank you, Wayne. Gay, please join us.
You bet. Thanks so much, Wayne. So I want to tell you about a study that Healthcare 21 did now almost 2 years ago. Many of you know that we have had a data warehouse for a long-standing time and periodically see things pop up in our overall data results that initially led us to look at migraines. I wish that I could be there in person with you, because I often look out over the employers in the audience and say, I have a dirty little secret about coalition directors, and that is that we can really read your mind. And I say that because I know from working with my employers, the topic of migraine, unless you are a person that experiences migraine, may be on your, yeah, I'm sort of interested, but not so sure about this topic. But I think with the information that we're going to share with you today, what we found in our study, you're going to see several reasons to be interested in migraines, because as Wayne says, it certainly is more than a headache. So about 2016, we did a data dive in our data warehouse where we looked at cost for migraines and indirect costs. And we called a roundtable of employers together. We handed them their individual sheet with their results on it and engaged in a conversation around migraines, quite frankly, to find out that they weren't very interested in the topic. And that puzzled us a bit. So fast forward, I worked collaboratively with a lot of the coalition directors. Neil Goldfarb at the Greater Philadelphia Business Group on Health actually had done some work in his past life around the quality of care for persons with migraines. And so Neil and I embarked upon a new study where we worked with Dr. Silberstein at Thomas Jefferson, who is a national expert on migraines, and he served as a clinical advisor. And we re-looked at how we had evaluated data. And so our new data objectives were around finding the prevalence of all migraines. And this is a key point for takeaway here if you're doing data analysis. Just looking at the pure migraine diagnoses itself is really going to limit your population. Because with Dr. Silberstein, we learned that suspected migraines, and we'll go over that definition shortly, really also plays into the demographic and prevalence of migraines. So we wanted to look further into healthcare cost and utilization, and also, once again, revisit indirect costs. So next slide. So we embarked on a year-long retrospective data analysis. There were 8 employers in our regional data. They were both national and local employers. And we analyzed employees and dependents, workforce age 18 to 64, really for the plan year of July 16 through 17. As Wayne mentioned, we excluded, if you will, the more devastating disease states that could cause headache out of our data evaluation. What we learned was that 1 in 4 households have at least one member that's affected by migraine. So next slide. This is the 3 groups that we compared in our data analysis. The confirmed migraine diagnoses. Number 2 here is the key secret sauce, I'll call it. And that is looking for those in your plan data that have suspected migraine. And we're defining that as persons taking these medications that are specific to treating headache, or those who present with 2 or more headache diagnoses about 7 days apart. And what we found when we added this group was that it almost was half of what the original diagnosed group was. So it really added to our data set. And then the 3rd group, of course, is no migraine. Next slide. This is the demographic profile of the data that we evaluated, and I think it mirrors the comments you've just heard. In the 25 to 44 age group, that's 23% of the diagnoses in our data. So looking across the data, this is very much a working age problem, but perhaps a little bit different than the chronic diseases that you're used to dealing with. This is occurring even in your younger employee population. We also know that females in our population were more likely diagnosed than males. So next slide. So now we're going to talk about what we found in the cost and utilization. Because overall cost and utilization is more expensive in a migraine population than a non-migraine population. And you can see here, looking over outpatient ED visits and medications, how those compared across the groups. It's interesting to me that the suspected population, that second column here, looks really similar to the confirmed diagnoses. And I think that's just sort of affirming for us the importance of identifying those with suspected migraine. We also know that the total medical and RX paid for the total migraine population was about $12,166 compared to $7,778 for those without migraine. So direct medical and RX cost for confirmed and suspected migraine patients is 56% higher than non-migraine patients. I'm going to give you just a few other comments that we learned out of our data that I don't have a slide on, but one was around imaging. And employers, this is where I'm going to say there's more news about migraines than just the headache diagnoses. because we found in our population that 40% of all imaging for CT scans and MRIs occurred in our migraine population. We also found that they had a higher prevalence of depression and opioid prescriptions. And Wayne mentioned that opioid prescriptions are not appropriate. But what we saw in our data was, despite those recommendations that migraineurs should not receive opioids as first-line treatment, over 60% were receiving opioids and barbiturates without first having received a lower risk medication. Also, about 14% of this population had a comorbid diagnosis of depression, and their healthcare costs, the migraineurs with diagnosis of depression, were more than double of those that just had migraine. This information was just recently presented, actually this month, at the American Headache Society. So I say to employers, not only are you concerned about migraine in your workforce for productivity issues, but you also have concerns looking at the impact on imaging, on opioid use, around depression. And this gives you a pretty robust reason to look further into this. Next slide. We did want to reevaluate indirect costs. That is a big part of the issue with migraines. And there is a migraine impact tool that's available from Amgen, free for use, that allows an employer to put in specific population, demographic, size, industry, etc. And then it will give you costs on a national data set that look at migraine. And so the next slide, you'll see that we ran this model, and in the model, we certainly saw that total indirect costs were very high, and in particular, I'll call your attention to presenteeism. So presenteeism is someone showing up for work, but perhaps they need a dark room or they need to lay down. They're not 100% present in their work activities for the day. And I think, you know, Cheryl teed this conversation up really nicely at the beginning when she talked about the World Health Organization saying that 90% of workers with migraine are unable to function normally. So I do want to call out there were some limitations to our study. That's the next slide. And that's just to say that it was a one-year retrospective study. It only included the 8 employers. But given that, next slide, I think that there are some key takeaways that we learned from our data analysis. And the main one is only looking at the migraine diagnosis will underestimate your population's prevalence of migraine and its impact. We also found in our data and confirmed that migraines have greater healthcare utilization and cost. And remember that direct medical and RX costs were 56% higher than in the non-migraine population. Indirect costs are significant, and I know for some employers that's more important than others. And for our employer group, that was a really strong reason that we went back to the data, because we did not have a lot of manufacturing employers, and they weren't as chiefly concerned about productivity as they were about actual cost. And then remember that migraineurs use a disproportionate share of imaging services. And in our case, we found that 40% of all the imaging was tied to the migraine population. So that's an overview of what we did in, I'll call it data analysis number 1 versus number 2, and the impacts of what we saw. So I'm going to turn it back to Wayne, who's going to talk to you about actually putting in a migraine education program.
Thanks very much, Gay. And that's a terrific introduction for the program that we have put in when I was at the bank, as well as American Express. I'm going to share with you the results of the program we did, and then Tom is going to share with you what they're doing with the program at published the results of this study in the Journal of Occupational Environmental Medicine a few years ago, and we're happy to provide a copy of it, and it's also on the MBGH website in the migraine toolkit. So we were involved in helping MBGH develop that toolkit, as well as the program I'll share with you. Amgen turned to us a few years ago and asked us to help them develop the same kind of program for their employees, and also this is really the basis for a website they have, as well as for the MBGH website and toolkit. So that's just a little background. So why did we decide to look at migraine? Well, first, the demographics of a financial service company shows you the impact of migraine in a working population. Financial services companies tend to have young employees, and they tend to have a predominance of women in the workforce, so it's an ideal setting and a reason for migraine. We also looked at data, and we had health risk appraisal data, and the health risk appraisal asked about several chronic diseases. Migraine was one of them, and we found that the prevalence of migraine in the population was pretty much mirrored the kind of data that Cheryl and I and Gay have shared with you. And finally, we looked at the medical costs and pharmacy costs for migraineurs and found, and this is old data, but found that the migraineurs costs were over about $5,200 a year compared to about $3,500 a year, very similar to the ratio that Gay found in their data, but our data was from 2012. And this did not include the cost of absenteeism, disability, and presenteeism, which we had published separately. So, in brief, the objective of the program was to offer a migraine education program to all of our US-based employees. And we wanted to evaluate the program, and the goals of the program are listed here. We wanted to enhance our employees' education about migraine and self-care. It was not only for migraine, but for a number of other chronic medical conditions, whether it be asthma, high blood pressure, other conditions. We developed various tools. This was an evidence-based program that we developed with the assistance of a neurologist and various other resources that were evidence-based. And then provided employees with a variety of tools, including information about triggers and medications. So here's a summary of the program. The methods are listed here, and the paper goes into the details. So I'm just going to describe things at a very high level. It was a multidisciplinary approach. So we had a neurologist talk about, in one of the webinars, migraine and other headaches. We had a psychologist from our EAP talk about stress as a trigger for migraine. We had a dietitian from our weight management program talk about dietary triggers. And we used a pharmacist from the PBM to talk about medications and approaches to treatment. So you can see that we were utilizing resources that we already had at the company, and the additional cost was really absolutely minimal. Communications are important for any program, as we know. So we used an intranet that we developed for employees, posters, flyers. Most importantly, because we wanted to evaluate the effectiveness of the program, we used a baseline questionnaire that included questions on demographics and treatment and depression and productivity and migraine symptoms. We had participants complete a questionnaire 6 months later, also after the program. So this is a relatively long program with a lot of information that went out to participants along the way. Incentives were minimal. We used some raffles. We used some subscriptions to some health magazines, but our experience with migraine program is that migraineurs participate in it because they want to feel better and their symptoms haven't been addressed. So the next slide shows you the results. In the initial program, we had over 500 employees enrolled. This was a virtual webinar-based program, 500. Subsequently, we had over 1,500 employees participate. It was the most popular program that we had offered at the time. We have information on about half the employees completed both a pre-survey and a post-survey, a 6-month post-survey. That doesn't mean that others dropped out, but a lot of them participated along the way. They just didn't complete the pre and post surveys for analysis here. The majority of people who completed the baseline and post survey were women, over 90%. And there were 72% of employees said they have migraine. Now, we found in follow-up is a lot of employees participated in the program because they had a family member with migraine. They had a spouse or a significant other, they had a child, and they wanted to know more about migraine because of the family member. And you've heard that theme earlier today. So what are some of the outcomes of this migraine program? Well, the first thing was that only 17%, about 1 in 8 employees didn't do anything, made no changes. The vast majority made some change or multiple changes, and that's summarized in this slide. About 2/3 of the participants identified triggers and eliminated some of their triggers. Half reduced their stress. And you can see a number of others. Some went to their physician and got changes in their medication or were placed on medication. But the majority who participated in the program made lifestyle changes. The next slide shows, next few slides will show you some of the objective outcomes from participating in this program. And again, these are the employees, same employees who completed a baseline questionnaire and we compared to their results at 6 months, the same group. In terms of severity of the migraine headache, the percent of employees with no pain went from 0 to 8%. From mild pain went from 3 to 18%. And moderate or severe pain in the past 4 weeks dropped from 77% to 35%. About half drop from moderate to severe to mild pain. You can see that great shift. The work effectiveness is in this slide, in other words, productivity. And those also, we saw significant improvement in productivity. Effectiveness at work, we had various measures. The number of percent of people that said they were not at all effective when having headaches dropped to 5% from 12%. But again, you see a significant shift in the 6 months. The next slide shows how the program was associated with decrease in absenteeism in the past 4 weeks. And the number of employees who had no absenteeism associated with their migraine headache increased from about 67% to 77%, 10% increase, had no absenteeism in the past 4 weeks related to their migraine. So again, you see a significant shift in productivity. Well, in summary, clearly we found that migraine was prevalent in these population. It wasn't shown, we didn't have the sophisticated ability to do the data analysis that Gay shared with you, but we had health risk appraisal data. The program was very low cost, and in fact, the program now is available through MBGH and through Amgen at no cost. The majority of participants took action from this program. They wanted to feel better. And the other thing that we found is that a significant number of people didn't know if they had migraine or not. They had headaches. Help them understand that their headaches were migraines so they can go to the physician, or we had nurse practitioners in our clinics and physicians in our clinics around the United States, and they could get some consultation with them also. So with that, I'm going to turn things over to Tom.
I have a real quick question for you, Wayne. Was that the biggest aha for you, that the last thing that you just shared with us?
Yes.
Yeah.
Absolutely.
Any other ahas?
People were diagnosed with sinus headaches or other things, stress, and they found that their headaches, once they went through the educational program, of course, many went to see their physician or one of our nurse practitioner clinics, that it wasn't sinus, it was actually a migraine.
What were the top two on that earlier slide? The second one was stress management, that they did meditation or stress management. I just wanted, because I found those both very compelling. Keep going. Yeah, right here. So engaged in relaxation and stress management techniques. That's almost 50%. That's pretty profound. And that also had to have had an impact on what they were doing.
That's correct. So one of the webinars was done by the clinical psychologist on stress management techniques, relaxation techniques, and additional information was available on the intranet site.
And then if they saw a trigger coming, were they able to utilize that as well as medication to help them?
Yeah, so for a lot of folks, it's just identifying the triggers,
right?
Eat medication and decrease the frequency.
You can fast forward for us. Thanks for sharing that with us. I wanted to capture you while we were still on that. Who's next?
This is Denise Gianvalvo, and what we're looking at now on the screen is a part of Amgen's toolkit that you can access through our toolkit, and this is the calculator that Gay had referenced earlier, where you can put in demographics on your population, and then it'll calculate the prevalence of migraine.
So you only need a little information, the defaults, but the percent of men, percent of women, age, and so forth, you can put in the calculator. It'll give you a good idea, estimate whether migraine is important in your population. It has lots and lots of information. You don't have to have all the information, but the more information you have for your particular organization, of course, the better the data will be.
Excellent.
And this migraine, working with migraine program is the one that my team originally developed and then was used for Amgen employees. There were about 500 Amgen employees that participated, enrolled in the program, and now Amgen has developed this website, which is part of the toolkit that MBGH has. This is information on that.
We're going to talk about our toolkit at the end.
Yes.
But is Gay up next?
No, now we go to Tom Sondergeld.
Oh,
with
great.
Walgreens Boots Alliance. And you put the next slide for him. And Tom, you are up.
Great, thank you, everybody. I appreciate being part of this wonderful group of people and to talk a little bit about Walgreens. I think most people know who Walgreens is, and so I don't have to go through a lot of stuff. You know, we have 12,000 stores worldwide, about 9,500 in the United States. 6 to 7 million people come into our stores every day. We have 250,000 employees. About 210 of them are part of, and their family members are part of our health plan. And we hire about 75,000 people a day. Next slide. So why think about migraine at Walgreens? not that Walgreens gives people migraines, but we hope that's not the case. But what we found in our data was that about 7,000 people have a diagnosis through our health claims for migraines. Now, some of those are probably dependents, but we are a heavily female population, and their average age about 34. And so we're starting to see a lot of migraines and severe headaches being diagnosed in our health plan. We know that those, from the data that Gay and Wayne have shown already, those impact productivity and absenteeism, and they're a big deal, and they really can affect the people around the person that's having the migraine. So we really just felt like it was the right thing to do. Plus, as a pharmacy, we have partnerships with PBMs and with other manufacturers that we just felt like it was time. And one of our partners approached us, United Health Group with Optum, approached us and said, hey, what do you think about doing something on migraines? And so we started down this journey. And the next slide, we'll talk a little bit about that journey. So a couple of months ago, we got together and said, why a migraine initiative? Well, as you've heard, we want to improve and engage employees who are experiencing this problem. Well, we want to help people have a normal existence with migraines and understand the triggers to get in front of them. We wanted people to engage with employees in the right way. Sometimes managers don't know how to deal with people that have a migraine, especially in a store where somebody might be having a migraine right in front of a customer. Well, how do you deal with that, and what do you do? And then we wanted to provide multiple employee resources for people to help them. So our pilot focuses on absenteeism, productivity, modifications that might be necessary to the work environment, migraine costs, and if they're in the health plan and pharmacy benefit formulary correctly, and then it provides sensitivity to others around the target that would be targeted for participation. Next slide. And so what we did is we partnered with Allergan and with Optum, so a manufacturer, and our PBM to look at this problem. We had a 2-day workshop with my team and all of their team. It was really a very engaging workshop. We uncovered many different avenues and pathways to deal with this problem. For family members who might have someone who suffers from a migraine, to a manager who might have an employee or a customer who's suffering with migraine, and then to the person who's suffering with a migraine. So we decided to build our phased implementation over the next year or so to kind of deal with that. I'm going to take a look at some analytics and do the design, which we're in right now. We're going to implement sometime around the first part of 2020, and then we're going to monitor and report on what's happening with this program, and really design the program around an app or a web tool that people can access, a quiz that they can take to know whether or not they're suffering from a migraine or their loved one is really suffering from a migraine, and then get them tapped into resources through the United Health Network and through Optum, so that can help them get the right help they need and get diagnosed and be monitored correctly. So that's kind of where we're at with this project. I'm really pleased with the work that we've done so far. The team is really, really engaged and highly motivated to try to solve this problem. A couple of the members actually suffer from migraines, so it's been really educational. And the next slide, I just like to remind people all the time when I get a chance to talk that wellness is not a one-time, one-done kind of thing. I was fortunate enough to go fishing with a net once. If you've ever seen anybody do this, these guys take these nets, they're usually little guys, they take these nets, they start out really early in the morning, and they toss these nets until they catch the last fish. They don't stop tossing the net until they catch the last fish. I think wellness is a lot like this. We tend to throw out a program, and then if nobody engages, we pull the program. Behavior change doesn't work like that. Behavior change happens in any moment, and when somebody needs the help they need, the help needs to be there. And I just always caution people that when you build something, don't just throw it out there, be mad because engagement's bad, and then pull it. You never know when somebody's behavior change moment is going to come, and behavior change is required at least 7 to 9 times before somebody actually changes their behavior. So just keep the programs going. Just like this one, it may serve a small population, but you never know. There might be a lot of people who are suffering from migraines that we're not actually capturing. So just really think about fishermen with a net and how much they work, and they don't stop until it's done, and that's what our job should be. So that's my little section on migraines.
Thank you. Thank you.
Cheryl.
So I wanted to share with you guys a little bit about the toolkit that we've been working on for over a year, probably a year and a half with Amgen. We wanted to have a toolkit that could serve as an enhancement to all the great work that Amgen and Wayne and others had already done, that would have our research behind it and include some of the elements that we felt were most important for employers. So you'll see at the left, we've got building a business case, an entire section on that, one on workplace strategies, and one on plan design and policies. We have two more sections on the next slide, but I'm going to employee communication strategies, tools and resources. But to go back, the business case includes a lot of important statistics and the impact of migraine on American adults and children that suffer. We've learned a lot about that from all of our speakers today. Economics and employer impacts covers examples of direct costs like doctor visits, medications, outpatient, inpatient, and even emergency room use. And of course, indirect costs, which we heard a lot about today, with 95% of sufferers unable to work or function normally during an episode. Productivity is a huge issue, and that was one of the aha moments that we had 2-3 years ago when we first started having conversations about this. And we knew that from all the work that Wayne has done and other employers like Navistar over the years. There's also in this section great data from a recent IBI survey, Integrated Benefits Institute. And then we also hear about how data can help. So it covers how the condition is often underdiagnosed and undertreated. And I think we can hear from everything we learned today that there is a lack of awareness with not only the employer and other key stakeholders, but especially with the patient, that the patient is unaware maybe that they have migraines and maybe not going to a PCP and not being appropriately diagnosed. So I think that's important. We look at data sources for migraine options, and there, as we heard earlier, there's a calculator on the Amgen site, which is in conjunction with ours, but there's also information on a very simple way that you can estimate the number of employees with migraines in your workforce. And we provide recommendations on how to use self-report information from employees and family members as well. Each section you'll see has, almost each section has a resources section, which not only is going to cite where we got the data, but it's going to include additional articles and papers because some people love to drill down further. Under workplace strategies, as Wayne talked about, you got to use your existing resources. You've got all these things that you're paying for or that you've put together. Now, how can you integrate that? You know, managing a chronic disease may have some differences, but there are things that you can borrow from the other stories. So we provide in this section recommendations how to tap into not only the existing resources, but what are you doing in terms of wellness and well-being, or EAP, or on-site wellness and fitness centers, chronic condition management, which is a great tie-in. And then if you're trying to develop a new program from scratch, how do you develop a standalone program? How do you set program goals? How do you use the data? What are the key program components? Are you going to integrate incentives? How are you going to evaluate the success of that program? We included sample pre and post program evaluations for you to use here as well. And as we talked about earlier, the Working with Migraine Amgen program is available at no cost, which has a lot of turnkey resources as well. That includes kickoff and session tools and resources that you can use. Under the work environment, we learned and are sharing actions that employers can take at the work site with workplace accommodations, even providing recommendations on how to accommodate in the workstation. I remember years ago when Navistar presented on this, Dr. Bill Bunn at the time would talk about the fluorescent lights in the manufacturing facilities. And even though migraine may be have more females. These were males that were primarily in that workforce, and how they were addressing those issues there. So understanding your environment and your culture matters here as well. And then this section includes employer case studies. So in addition to what we learned today, it has a couple great case studies for your review. The plan design and policy section looks at plan design related to drug treatment, managing your formulary, information about the new therapies. So the latest therapy is a new class of drugs called GCRP, and it provides an overview of what that is and how it's a little bit different from some of the older drugs, which had a lot of side effects. And then we also talk about non-drug therapies, and stress management programs and the like are good examples of that. There's information on workplace policies, including examples that you can put in place to accommodate employees with migraines. We think that's very important. We included information from the Americans with Disability Act that includes links to determine if a person has a disability and about migraines and the ADA, including questions to consider. There's also information about FMLA and a resources section. We talked about employee communication strategies, and as I mentioned earlier, awareness and education is the first step when you're working with employees and family members. So we've included recommendations on ways to incorporate the migraine management into existing programs, how to get the conversation started with employees, how to promote your program, including helping them identify triggers and early warning signs, and then targeted communications for specific program elements like programming, benefits, tools, incentives, self-care, and understanding their benefits. We included a section on communication tools and challenges, which offers templates, brochures, and posters that you can cut and paste in at no cost, and even information and guidance on where to find good and where to post good web-based information. There's also information on mobile technology. There's an app that we've included a link to for headache diary, and then how to use on-site staff to support people at the work site with these issues, and what vendors you should partner with. And then finally, the resources section here has a section on employees and dependents, so resources just for them, things that include migraine triggers, diagnosis, treatment and prevention, preparing for a doctor visit, finding a headache specialist, and information on available mobile apps. There's a section for employers, and then more information on customizing your own tool. So it's pretty easy to use. It's completely at no cost, not only to MBGH members, but to any employer or stakeholder in the country. We hope you take advantage of these resources and all of our employer toolkits. So if you go to the home page, you'll see the URL to the migraine toolkit at the bottom of each of these two slides. But to access all of our toolkits, go to our home page, the resources section, the sub-menu bar, employer toolkits, and you'll see the 5 or 6 that we currently have on various important topics. And I'm going to pass it over to Denise, who's going to walk us through a Q&A session.
Yeah, thank you, Cheryl. So as each of you gets your questions together and sends them over through the chat box, I have a couple of questions to ask our presenters. I will start with a question that is directed to Gay and/or Tom, whoever wishes to respond. Why is migraine on your coalition agenda, and how have you approached the topic?
So Denise, I can tell you what Healthcare 21 is doing. So from the project that we did with Neil, where we reevaluated our data, we actually developed a dashboard to report that information back to the unique individual employer. And we're sort of in a process. We're about to reorganize our efforts on migraine around a Choosing Wisely project, where we are going to produce our annual consumer guide around choosing wisely, how to talk with the physician, what about opioids and imaging, but around the migraine topic. So we have sort of an employee approach that the employer can use, and then we'll have the employer information to show them the direct and indirect costs amongst their employee population, and to engage them in the activity of the Choosing Wisely on Migraines.
Interesting. Thank you for sharing that with us. So along that line, Gay, how does migraine most often, or rather, migraine most often does not show up in the employer's data? So what or how did HC21 look at the data differently? And how are you doing that now as it pertains to working on this project with Choosing Wisely?
Well, I think that is the key takeaway from the work that we did in the second round, where Dr. Silberstein, informed us you really have to look at suspected migraine diagnoses by those drugs that are specific to migraine, because we know that Botox, for example, is used to treat migraines, but we didn't include Botox because it's also used to treat cosmetically and otherwise used. So we limited our evaluation at looking at the drugs specifically used around migraine, and then those repeat visits, two or more visits in less than 7 days, to expand the population so we could really see what was happening with cost, both indirect and direct.
Great, thank you. Tom, do you have anything to add to that as you are starting your initiative and looking at data within Walgreens?
Yeah, I mean, I think, certainly we've wanted to look beyond just normal data, right? And, whether or not somebody is using the right pharmaceutical mix, whether or not that's impacting medical cost or productivity costs, whether or not it's affecting disability spend, leave of absence. And so we're trying to look at it from a more holistic point of view and trying to uncover the data that really makes sense to track and to see how we're impacting the population as we try to intervene as much as we can. Self-reported results are good, but I think we need to have some more grounded results that make sense. And I think a part of our project is trying to define that data set that's going to make the most sense.
That's great. Look forward to seeing what you end up with, the final numbers. Wayne, I have a question for you. How have typical or complex migraine that don't present as a typical headache been incorporated into your analysis, and how do we address it?
Yep, so it's a good question, and this was something that was addressed by the neurologist that we used as part of the webinar. So to help employees understand what the data was, what the differences were, and that's why I think having a neurologist, and not just a general neurologist, we used one in New York that specialized in headaches and migraine in particular, to help sort out, as part of the webinar, these different types of migraines that you referred to.
Thank you. Any questions coming through? Cheryl.
Well, I had a quick question for Gay. Gay, how did Healthcare 21, you may have mentioned this and I missed it, get to the presenteeism issue? How were you able to track? Was that a self-report survey with the patients that participated, or were you able to get to the presenteeism issue quicker in a different way? Excuse me.
Sure. So we did not have that type of employee response. And so we used the cost calculator that Amgen provided. The very first time we did the study, we actually did one of the IBI. We took their percent rate and applied it across the board. But the Amgen calculator gives the employer a more specific look to their input. And that would be my recommendation.
Well, that's fantastic, because they already have done the work and the research to know what those numbers on average are, because there's no way the average employer could get that information. So thank you for qualifying that.
Yeah.
Any questions? Go ahead, Gay.
There's just one other thing that I don't think we've mentioned. that is an important consideration for the employer, and that is that your employees are quite interested in this topic. We offered a lunch and learn around migraine management, and it was amazing how many employees came. And it was just as described before. It was folks that were experiencing migraines, but there were a lot of family members coming to see, am I missing anything? Is there anything new? And so there is updated new information about managing migraines. And just having the opportunity, I think, for employees to sit with their peers and talk about an issue they deal with was a really valuable employer-sponsored event.
That's awesome. Great.
Yeah, I've got a question here. How can employers measure the success of their migraine education program?
Well, maybe I can take a stab at this. We included a pre and post test questionnaire, and that's part of your toolkit. And in that questionnaire, you ask, and we ask and reported on the effect on absenteeism, productivity. There are standardized questions on productivity. And I'm not going to get into the weeds, but one is called the MIDAS, and then the one we used was a form of the work limitation questionnaire that was developed at Tufts by Dr. Lerner. So there are standardized questions for migraine. You can look at utilization of different services as we did. So what changes did people make? Did they change their and looked at their triggers? Did they participate in EAP? Did they go to the doctor? And so forth. So all these questions are available, and we found that self-report is really quite good for this. And then for those employers that are sophisticated, they can certainly look at employees and see, did their claims change? Was there less use of opioids in migraineurs? Was there less emergency room visits and less imaging? So those are longer term studies using claims data and linking it to people that participate in the program. So for most, I think self-reported pre-post participant questionnaires is a good way of going at it, and then there's much more sophisticated ways that can be used too. And Tom, do you want to share what you plan to do with your program evaluation?
Yeah, so Wayne, we're going to use the pre and post quiz. So we're trying to pick the right one that makes sense, but certainly a measurement, and then some longitudinal analysis throughout the whole process. So kind of like daily, how do you feel checkpoints. That self-reported anecdotal data really helps. But we're also going to look at medical claims, pharmacy claims, certainly opioids and other pain medication, and then look at productivity measures as much as we can, and disability and leave of absence. We may even throw out there some managers who might want to participate, and whether or not they feel like there's been an impact at work, to kind of get like a third party oversight during our study period. So we'll use as much as we can and see how far we can push it. But I do think there's two avenues we're looking at that makes the most sense, which is the self-reported numbers, and then the claims data all along the lines from the productivity and leave data as well.
Thank you. So we know from the work we did on the migraine toolkit that women are more apt to have migraines than men. We have some manufacturers on the line who may not have a large female population on site, but we also know that the caregiver is greatly impacted by having someone at home with migraines. So have you, Wayne, or Tom or Gay, addressed anything in terms of reaching the dependents or spouses at home who can be impacting your employees? productivity?
Yeah, I think that's an important question, Denise. Before I left, started opening up the program to spouses and partners of employees that have migraine. Especially their interest is not only for themselves, but for the kids in the family. And more kids are diagnosed with migraine. It's no longer thought just a problem of adults. So, and then the caregiving issue, which is absolutely significant. It has to do in part because when someone has migraine, the research shows that they have to miss various events. They can't go to, they're so ill, they can't go to an outing, or they can't go to some social function that was planned. So we found from that standpoint, there was a lot of interest in participation. So anyway, I'll kick things over to Tom and Gay for any experience they have in this area.
Yes,
I don't have anything to add on that one.
yeah, we're spending an awful lot of time looking at the impact in the workplace. So coworkers and managers and those people who might be the caregiver in the moment. And so that's kind of where we're spending a lot of our energy in this particular piece. Certainly the home is important, but especially if the person is not a direct employee. But if it's an employee, we certainly want to look at the workplace around them and make sure that those people are supporting and educated and understand, because I think there's a lot of bad reputation about people with migraines, and we want to cover that and make sure people are supportive.
I'd like to add, Tom made a very important point. Our experience was that the number one reason for intermittent family medical leave requests, intermittent, the ones in 2 days, was a headache, but primarily migraine. And a lot of supervisors and managers think, well, why are they missing a day, or why do they have to leave early just because they have a headache? And so, as Tom mentioned, that education of the leaders is really a key part of this. That it's a disease, and people are not just taking time off unnecessarily. And by encouraging them to participate in the program, they can decrease that intermittent family medical leave time.
I like that, and it may be that we revisit our toolkit, even though all that information is in there, a way of saying leadership education to remind them that we all benefit from those learnings.
Well, I'm not seeing any additional questions at this time. I think this would be a good time for us to wrap up and thank everyone who's been listening, and particularly thank Wayne, Gay, and Tom for taking your time to educate all of us today. Appreciate having you here with us.
Great.
Thank you, everyone. Go ahead, Tom.
No, thanks all the participants. We appreciate you coming.
Hope to see you all at the September 11th annual member meeting. Have a great week, everyone.
Bye now.